Cadlick. Always nice to be out here. I was reminiscing. I think when I came out here, Jimmy Chua was the only ID doc. Brian York had just been hired, which if that dates me, there you go. And I think Cadlick was a lot smaller than it is now. Well, I'll just start off by saying that I'm impressed that this was a requested topic. Infection prevention is not glamorous. It is not particularly sexy, and we'll see if I can try to keep you awake here. But it is foundational to everything that we do. Actually, I can take this off now. Being a good representative of this talk. But it is something that we all have to do, and we all have a role in it. So most of what you're going to hear is, I think, are going to be things that you know, maybe a little bit of reinforcement. I'm going to try to hit some of the common opportunities I see where people could improve. And then at the end, we'll talk about a little bit of the stuff that is potentially newer that you may or may not have heard of yet. Yeah, I have no disclosures. You know, my joke is I'm an infectious disease doctor. I'm lucky that I get paid to work. No one pays me to do anything, so you don't have to worry about that. So let's just start with the basics. And really all of this talk is probably just ripped straight off the CDC website. So if you want to go look, I've got some links in there so you can go click on them if you want to go see it. But we'll start with a little quiz. Which of the following conditions do not need droplet precautions according to CDC Appendix A? So A, influenza, B, parainfluenza, C, RSV, or D, human metapneumovirus. So these are all, I think, what we would call respiratory viruses. And the answer actually is, I'll pause just so you can think about it, but it's B, C, and D. None of these per CDC need droplet precautions, which is a little bit of a head scratcher. And it comes back to what are standard precautions. So we'll get into that. Which of the following require contact precautions? Anthrax, cholera, bacterial conjunctivitis, cleaning up stool on a patient who you've already shown is C. diff negative, changing bandages on a wound in a patient who has MSSA. So the answer is D and E. So A, B, and C do not need it. D and E are, again, because of standard precautions. So what are standard precautions? First and foremost, hand hygiene. You know, if you take away anything from this talk, I think you already know this. Cleaning your hands before and after patient encounters, before and after touching dirty things is the most important thing that we can do. Keeping things clean, right? That's the key. So if the room is dirty, you want to make that clean. If you have shared medical equipment, things that are going from patient to patient, that should be clean. It's also focusing on injection and medication safety, minimizing potential exposures, and reprocessing of reusable medical equipment. So when do you wash your hands? I mean, this is kind of a no-brainer, but people confuse this. I think there's been a lot of emphasis on in and out of the room, and so we do a pretty good job with that. Where there's still opportunity is all of the other times within the room. And so this is from the CDC. You should clean your hands immediately before touching a patient. I think that makes sense. Before performing an aseptic task or handling invasive medical devices. Before moving from work on a soiled body site to a clean body site on the same patient. That one, not often done. After touching a patient or the patient's immediate environment, okay, that makes sense. After contact with blood, body fluids, or contaminated surfaces, hopefully we do that. And then immediately after glove removal. So one of the key points, one of the key pitfalls that I see in my practice is team members believe that the gloves are a substitute for hand hygiene, and they are not. So if you take off gloves, you need to then clean your hands that you clean before you put them on. And I think that's a common mistake that we see frequently in the hospital, and that you will get called out on if that's seen by anyone. The other way you may hear of this are the 5 moments. This is from the WHO. So the WHO has a slightly different version of this. It's kind of the same idea. Before touching a patient, before a clean aseptic procedure, after body fluid exposure or risk, after touching a patient and after touching the patient's surroundings. So it's kind of the same idea, but it's phrased in a different way. From a regulatory standpoint, your institutions have to follow one of these two approaches in terms of their policies. So you may hear both of them. So 2 ways to clean your hands, not to insult you. Alcohol-based hand sanitizer, that is one of the common things that we do. And that is a wonderful thing, actually, because it allows us to clean our hands quickly, easily, and frequently. And I always joke that when I get spoiled, because at work, there's like a alcohol-based hand sanitizer dispenser everywhere. Like I can just go from hall to hall, room to room. They're just scattered about, they're plentiful. And then I go to the mall, and I used to joke when my kid was younger that we'd go to the little playland where they have all the little bouncy balls and everything else that in my mind, is just full of nastiness. And I desperately want both myself and my kids to clean their hands. And of course, there's nothing there. And I actually, at Bellevue, the Bellevue Mall, there was one dispenser that was always empty, and it just used to piss me off to no end. But it works, and it's a great thing. Of course, the other old-fashioned way is soap and water. This is quick and dirty, quick and easy, I should say. For people that can't tolerate the alcohol-based products, soap and water is okay. I will say that the CDC recommends, if possible, to use alcohol-based hand sanitizers preferentially if there's not a reason not to do it. So alcohol-based hand sanitizers are the most effective products for reducing the number of germs on a healthcare provider's hands. Alcohol-based hand sanitizers are the preferred method for most clinical situations. And the reason is alcohol-based hand sanitizers kill more organisms than soap and water and are easier to use during the course of care, easier on the skin, and don't require a sink, i.e. they are more likely to be done, and any hand hygiene is better than no hand hygiene. And so it is something to remember. When do you want to use soap and water? So if your hands are visibly soiled, remember the alcohol is just going to rub around your hands. It's not going to take anything off of them. Before eating, and I try to do this. I try to follow what I preach here. And so before I eat, I will go and wash my hands, knowing that the alcohol, especially in the hospital, I'm always paranoid that I'm going to get C. diff from somebody. After using the restroom, after caring for a person with suspected infectious diarrhea, and of course for a known suspected exposure to spores, like anthrax, unlikely, more likely C. diff. And so I think norovirus could be on there too. I think you know this, that for C. diff, if you use Purell or an alcohol-based hand sanitizer on your hands, all you're really doing when you rub it around is you're moving the spores around, and when it evaporates, they're still going to be there. And so that's why washing your hands, soap and water doesn't kill it. You're just physically getting them off of your hands. So how do you wash your hands? This shouldn't be controversial, but it is. So wet your hands with water, apply the amount of product recommended by the manufacturer. Typically, if everything is set up appropriately, when you push in a dispenser, you want to push it all the way in because it's set to dispense just the right amount. You would be surprised at the number of meetings I've had debating in the hospitals how much of something should come out. Because there is somebody somewhere trying to figure out how much money am I saving by reducing the fraction of a dispensing aliquot over the course of the life of the machine. But it is all tuned to what should be the minimum effective amount. And so push it all the way in, rub your hands together vigorously for 15 to 20 seconds, covering all surfaces of hands and fingers. Rinse your hands with water and use a disposable towel to dry. Use a towel to turn off the faucet. Which looks kind of funny, but I've gotten used to it. Avoid hot water to prevent drying of your skin. The 15 to 20 seconds is, 15 is recommended by the CDC. Some other professional societies recommend 20 seconds. The CDC makes a comment that the time is less important as opposed to covering all the surfaces. Alcohol-based hand sanitizers, again, put the recommended amount of product on your hands and rubs together. Cover all surfaces on your hands until they feel dry. So essentially you're rubbing until it's dried off. Should take around 20 seconds, and that's the amount of time it takes to try to kill what's on your hand as well. And again, covering all the surfaces is probably the most important part to this. Places that people forget, which is why there is an emphasis on how to wash your hands properly. So the thumbs, the fingertips in between the fingers. So, the way that they teach us to do this, right, is to wrap your hand around your thumb, go in between, and then the fingertips, almost like you're scrubbing in for surgery, to wash it that way. So for gloves, you wear gloves according to standard precautions when it can be reasonably anticipated that contact with blood or other potentially infectious materials, mucous membranes, non-intact skin, potentially contaminated skin or contaminated equipment could occur. And this is where I see a lot of mistakes. The problem with the CDC guidance, to me, is that they call out certain things where they want you do a certain type of precautions, and then for other things they say you don't need to. But that's because they're assuming for standard precautions that you are doing something. So that if you're taking care of a wound, you're supposed to have gown and glove on. If you're changing a dressing, gown and glove. If somebody's pooped and you're cleaning it up, whether or not they have C. diff, gown or glove, that's kind of assumed. If your patient is coughing in your face, you're supposed to have gowns and gloves on, or I'm sorry, the mask on. And these are things that people forget. And we have, again, lots of meetings about should human metapneumovirus, which I think I would argue is spread by respiratory as well as by fomites. Should you wear a mask or not? And there's a big contingent that says no, the CDC says we don't need to. And then there's another contingent that says, well, that's because they're assuming that if they're coughing, you're wearing a mask. But we make it easier for our team members by saying if they have this, then they should just wear a mask. So that is a perennial debate. And I wonder, the CDC actually is revising their guidance for infection prevention and the tables shortly. And I wonder if they're going to come out with something new about that or not. Gloves are not a substitute for hand hygiene, as I already said. If your task requires gloves, you need to perform hand hygiene prior to donning, which means you got to do it far enough in advance that your hands are dry to get the gloves on, and then before touching the patient and their environment, and then you perform hand hygiene immediately after removing gloves. Like I said, don't think of the gloves as a substitute. If you take off the gloves, you still got to clean your hands. Change gloves and perform hand hygiene during patient care if gloves become damaged. That's self-evident. They're visibly soiled with blood or body fluids following a task. Just go ahead and change it so you're not spreading that everywhere. Moving from work on a soiled body site to a clean body site. Hopefully that's self-evident too. Going from dirty to clean, you want to keep clean. And so change, clean your hands, change the gloves. Never wear the same pair of gloves for the care of more than one patient. So don't put on gloves and walk from room to room. I don't see that much from providers. I do see that from EVS staff and the people that go around and clean the sharps container or change the sharps container. So those kinds of things we have to work on. And of course, remove your gloves, any PPE, in a way that prevents you from contaminating yourself is key. I think Ebola is the best example of this. I mean, we don't find a lot of things where you have this zero-sum phenomenon where if you touch it, you will likely die. But it does illustrate just how easy it is to contaminate yourself with taking off your PPE. And that's true for other things. You may not die if you get flu from your mask as you take it off, but it is appropriate to remember that it can happen. And if you do it properly, hopefully you'll protect yourself. One of the other core tenets, of course, of standard precautions is environmental cleaning and disinfection. And this is pretty self-evident. Routine and targeted cleaning of environmental surfaces, places that are closer to the patient, should be cleaned more frequently because they are going to have a higher burden of stuff. And the further away, things that are touched less frequently get cleaned less so. So one of the things that you probably all have heard of now is high-touch surfaces. I think COVID made this common phrase in the community. Things that are touched frequently should be cleaned more frequently. So an example would be like the elevator buttons in a building. Those are supposed to be cleaned on a more frequent basis than other things in the building because they are touched more frequently by a lot of people and have a higher risk of being dirty and of infecting other people. Promptly clean and decontaminate spills of blood or other things. Select an EPA-registered disinfectant that works against the thing that you're trying to clean up. So if you're trying to clean up C. diff, for example, and you're using a quaternary ammonium SaniWipe, it's not going to kill it. And so you have to use something that works. Bleach works. That tends to be what people use. And so just remember, you got to use the right thing for the right product, or the right product for the right bug. And of course, then follow the manufacturer's instructions. This is another area that I continue to see opportunities to improve throughout my organization. This has been true everywhere I've ever worked. People think they know how to clean something, and then you pull out the instructions from the manufacturer, and they're very different. From a regulatory standpoint, if you are not following the instructions for how you're supposed to clean something, the state, county lawyer is going to come back and tell you, well, you didn't clean it at all. And in defense of those people, the company has attested in some way, hopefully through some testing, to the FDA that by following their instructions, you're able to clean effectively their product. And if you don't follow their instructions, they can't tell you that it works. And that's where you go down this rabbit hole. And so the easiest thing to do is to make sure if you're cleaning a product that you've read the instructions and that you know what you're doing and you're following them. And someone also has to keep up on them because they change. People report problems to the FDA, they tell the company changes it, and you've got to change it again. So just be aware. Injection and medication safety, of course, is a big deal. This is a big target for a lot of regulators. I think it's important. You want to make sure that the meds you are giving your patients are clean. And so you want to prepare medications in a designated clean medication preparation area that is separated from your dirty areas, including sinks or other water sources. And we'll talk a little bit about water splashes later on. Use aseptic technique when preparing and administering medications. Disinfect the access diaphragms of medication vials before inserting a device into the vial. So every time you stick a needle into a vial to suck something out, you've got to clean that top. Doesn't matter if you just cleaned it. The next time you do it, you're still supposed to be cleaning it. Needles and syringes for one patient only. I hope that is clear to everyone. Includes manufactured prefilled syringes and cartridge devices such as insulin pens. There have been lots of cases of spread of hepatitis this way when people are reusing them. The other things that get reused is a healthcare provider team member who is diverting drugs for themselves, and so they'll take some and then give the rest to the patient. That also has led to hepatitis outbreaks. If you're entering a medication container with a new needle, it has to be with a new needle, a new syringe, even when giving it to the same patient again. So there's just a lot of safety measures that the government has mandated and put in place because of outbreaks that have happened. And you just have to think about that it's a new, every time you stick something into the bottle, it's a new needle, new syringe. Ensure if it's a single dose or single use vial, ampule, or bag or bottle that they're used for one patient only. There are multi-dose vials out there. You can use them on multiple patients. Again, cleaning the surface before you stick a needle back in with a new needle and syringe each time you put it in there. But if it's a single-use bottle, you cannot use it on two patients, even if there's enough volume in there to do so. So just be aware of that. IV tubing is for one patient only. Dedicate multi-dose vials to a single patient whenever possible. It's just safer. And then wear a face mask when placing a catheter or injecting material into the epidural or subdural space. That has been controversial for a long time, but that is the recommendation. I think that's mostly done now. But there was a time where there was a lot of anesthesiologists, neurologists, people who do a lot of LPs and sampling of the epidural space that they just didn't think it was necessary because they had never done it before, but it is a requirement. Use appropriate PPE based on whatever you're doing. So wear gloves when it can be reasonably anticipated that contact with blood or other potentially infectious materials, mucous membranes, non-intact skin, potentially contaminated skin or contaminated equipment could occur. Again, trying to protect yourself here. If you're going to do something that is dirty, could be dirty, please put on appropriate PPE. Wear a gown that is appropriate to the task. Protect yourself from anything that could splatter, spray, get yourself dirty, and then use protective eyewear and a mask or a face shield to protect the mucous membranes from the eyes, nose, and mouth during procedures and activities that could generate splashes or sprays of blood, body fluid secretions, or excretions. The number of people that come to me in my employee health role where the nurse is removing an IV, there's a little plastic part that's inside the vein, and they're taking it out. And in the act of taking it out, that plastic thing flips and it splashes their eyes. And then they're like, oh no, this patient has HIV or hepatitis, whatever. And they come and see me. And I'm like, you're supposed to have eye protection when doing that. And they're like, they usually say yes, they know, but they just don't do it. It's never been a problem until it was a problem. And it's just these rules can seem burdensome, but they're there for a reason. Remove and discard PPE. Upon completing a task before leaving the patient's room or care area. This is another general principle. As you go in a room, so the patient's room is considered their room. it's dirty. It's where all of their stuff is. When you go in, you put on your garb to protect yourself, you go in the room, and then as you're leaving, you take it off. So by the time you leave the room, you're supposed to have everything but your respiratory protection off. Do not use the same pair of gloves for the care of more than one patient. Again, we talked about that. Do not wash gloves for the purpose of reuse. I swear I was at a dentist's office recently with my mother where they had a pile of gloves that I think they were cleaning. I asked them, they said no, but do not reuse gloves. I used to work in India and we did that. We actually would take the gloves, they would fill it up with water, look to see if there was any leaking coming out, and then they would kind of clean them and hang them up to dry. Don't do that. It's not worth it. Ensure healthcare personnel have immediate access and are trained and able to select, put on, remove, and dispose of PPE in a manner that protects themselves, the patient, and others. We're doing this at Virginia Mason right now, where we're making everyone actually demonstrate to their manager that they know how to do all this stuff and sign a piece of paper saying that they know how to do it. Partly it's to ensure that they've been told what to do is correct. Partly it's just to be able to demonstrate, like, look, we told you, you signed it, why are you not doing it? Because we're making a real push here to try to get everyone to follow all of this guidance appropriately. Another core tenet of standard precautions is to minimize potential exposures. So have systems for early detection and management of potentially infectious persons at initial points of patient encounter. So this gets to screening patients when they come in. Do they have respiratory symptoms? Have they just traveled to an area where an outbreak is happening across the world? You need to have some way to try to identify people upstream to protect everyone else downstream. Encourage respiratory hygiene, cough etiquette. I think you probably all have signs up still at your facilities telling patients and yourselves what to do if you're coughing, if you're sick. It's just good general advice. If they have respiratory infections, contain their secretions, perform hand hygiene, whether that's tissues, masks, supplies, signage, do it all. And of course, when space permits, separate patients. Pediatric practices do this well. They tend to have like the sick room and the well room. Adult practices, we don't do this as much, but it is kind of a core tenet. If you're able to do it, especially as respiratory season ramps up, it's good to have a place where you can park the people with respiratory illnesses and to keep everybody else separate. And controversially, during periods of higher levels of community respiratory virus transmission, consider having everyone masked. We'll talk about this in a little bit. Reprocessing reusable medical equipment, clean and reprocess equipment. This includes BP cuffs, oximeters, endoscopes, stethoscopes, prior to use on another patient or when visibly soiled. Maintain separation between clean and dirty soiled equipment to prevent cross-contamination. You would be surprised at the amount of shared medical equipment that is not cleaned appropriately, and that could be cleaned at all. That could be cleaned according to the manufacturer's instructions, where if you ask them, they don't even know what they are. That could be using the wrong type of wipe. That could be using the wrong or the right wipe, but for the wrong amount of time. And it is a risk. I mean, there's plenty of reports in the literature of people who have been infected from blood pressure cuffs or oximeters or ultrasound probes going from patient to patient to patient and not being cleaned appropriately. And this is something that regulators are really focusing on right now. And I think it's legit. I think it's something that we should worry about. All right, transmission-based precautions. All of that standard precautions is what you're supposed to do all the time, every day. It's actually the part that's most commonly forgotten by everyone, but is the foundation of everything else. Transmission-based precautions, this is what I think we think of when we think of infection prevention. This is contact precautions, droplet precautions, whatever that may be. These are specific things we do for people with documented or suspected diagnoses where contact with the patient and their stuff poses a substantial risk of transmission, either to yourself or to other patients, and we do special things. And this is, you don't have to have a diagnosis. Again, syndrome suggestive of. So meningitis, droplet precautions, right? In case it's Neisseria meningitidis or Haemophilus. It's typically not those organisms, so you don't actually need precautions for all the other ones. But for those, till you know better, you do it. And meningitis is one of the ones that always creates a swirl. I get a lot of phone calls in employee health after that saying, a patient has meningitis, I need Cipro or I need rifampin or some sort of prophylactic antibiotic. But we don't even know what's wrong with them yet. And actually the rules to be exposed are pretty stringent. So for most of the time, we can get away from doing that. The stupidest thing I've ever done in healthcare, I don't know if this is a true statement or not, it's one of the stupidest things. As an ID fellow, we used to go to microbiology and we used to sniff plates. I don't know if anyone is old enough to have done that. And there was like clues, like it smells a certain way, you know what it is. It's a hint to what's going on. This has now fallen out of favor. I don't think we do this anymore. But I was at the VA in Seattle, and there was a plate that I just kind of, it was on display. I just picked it up and sniffed it. And then the micro lab director was like, "Oh, I probably should have wrapped that in a bag." And I said, "Why?" And she's like, "Oh, that's Neisseria meningitis, you know." And we had this debate about if I needed to take prophylaxis or not. But if you know me, I'm like total hypochondriac. And so I'm convinced if I take an antibiotic, I'm going to get C. diff. And I actually can say the only antibiotic I have taken in my, at least since I finished medical school, was this one that I did ultimately end up taking for meningitis prophylaxis. But so don't sniff plates in microbiology is a general rule. Try and place patients in a single room or cohort them if you can, and notify accepting facilities about transfer if somebody's on precautions. That's something that I think there's a lot of opportunity for improvement too, is to tell patients going from place to place, you know, do we know that they have something? Are we suspecting something? Are they in precautions with us? And actually, when I lived in Utah, it became a state law that you had to tell, for at least certain organisms, that it had to be told to the other organization. In Washington State, that's not the case. It should be told. But there is no must. So contact precautions. This is a barrier precaution to prevent the spread of organisms on healthcare workers' clothes and hands. I think it's pretty self-evident. You put a gown on, you put a glove on. Try to put the patient in a single room, minimize patient transport, and use disposable or dedicated equipment. So I'll just give you I'll do that later. Enteric precautions. We have enteric precautions at Virginia Mason. I don't know if anyone else has these. This is actually not a recognized CDC precaution, but we do it, again, to try to simplify the guidance that if you have someone who you think may have an infectious diarrhea, something that may not be killed with an alcohol-based hand sanitizer, that you wear gowns and gloves, but then you wash your hands before you leave the room. And so we've done this at most places that I've worked, but it is actually, just so you know, it's not part of the CDC guidance. Droplet precautions for patients with known or suspected to be infected with pathogens transmitted by respiratory droplets. When a patient's coughing, sneezing, or talking, source control, put a mask on the patient, try and keep one patient per room, wear a mask with eye protection when you go in the room, and limit transport of the patient. And COVID made that clear to all of us. Airborne precautions, which we were doing for COVID for a while, still are if they're getting an aerosol generating procedure. But this is patients with known or suspected to be infected with pathogens transmitted by the airborne route, so TB, measles, chickenpox, herpes. Put a mask on the patient, put the patient in a AIIR room, which is, we kind of call negative pressure rooms, but it's a certified room. Restrict susceptible healthcare personnel, so if the patient has measles, don't send someone in there who hasn't been immunized against measles. And wear a fit-tested N95 or equivalent respirator, cap or PAPR, if you have them. Limit transport, and of course, vaccinate healthcare workers if you can. So, all right, so what's wrong with this picture? This is actually out of a military publication. The US Army was posting this to talk about something, but you know, I saw this, and this illustrates a common pitfall of people, at least in my hospital. So this woman is wearing, this is obviously early in the pandemic. We don't do the double masking like that anymore. But she's wearing her gown and it's not tied. It's like wide open in the back. So if you're going to wear the gown, you got to wear it properly. If a regulator comes by and you haven't tied the gown, so tie it in the top. If there's a tie in the top, tie it in the back. If it's not tied, they're going to say you're not wearing it. So just remember to tie your gown. I've seen all sorts of things. You know, if your gowns have thumb holes, you need to use the thumb holes. If you put the gown on and you use the thumb holes, but you don't wear gloves, that doesn't count. And my all-time favorite, we had an ICU attending who only, he still, I think, only works nights. I don't want to give him away, but who I went in there at night. For some reason, I was there late at night, and he had his gown on, And he had it tied at the top and the back, but he didn't put his arms through the arms, so the sleeves were kind of tied back behind the strap in the back. And so it was more like an apron, like what you had in chemistry class back in the day. That is not correct, if anyone had any questions, so don't do that. It's interesting what you see when you go looking. What's wrong with this picture? I've blanked out the face to not shame anybody, but you cannot have your mask dangling like that. I have to say that when I was a medical student and I was doing my surgery rotations, I think I pretty frequently did this. But this is incorrect. If you take the mask off like that, you need to take the whole thing off and put a new one on, and you will get cited by a regulator if they see this. All right, new things. So just briefly, what to do with COVID. Source control remains an important intervention during periods of higher community respiratory virus transmission. They don't tell us what higher respiratory virus transmission is, though. And they've actually said at this point, all of the metrics that they used to do that would tell us community transmission levels that we had to do different things based upon are no longer available because of the changes in reporting after the expiration of the emergency mandate. And so now they essentially say you should figure out what makes sense for your community of when you would go back to using universal source control, which is eminently frustrating to me that it's now just up to me to decide. The benefit is greatest when there are higher rates of respiratory infections in the community. Okay, I accept that. All who want to be masked based on their own risk tolerance should be able. Okay, sounds good. Some centers may choose to mask during respiratory viral season, they say from October to April. And that's kind of getting back, if you don't have metrics, at least you can do it during respiratory viral season. So the Northwest Healthcare Response Network is it's an independent organization, but it's kind of funded by the CDC, funded by the state. They collaborate with all of the healthcare organizations within the state, have helped to coordinate, at least west of the Cascades, a shared policy statement amongst healthcare organizations about what we're going to do. Because what I don't want to do in my role as an infection prevention, I hate to get these emails saying the University of Washington is doing this, Swedish is doing this, Providence is doing this, Multicare is doing this, Kaiser's doing this, whatever it may be. I want us all to be the same. And so this was a way to get everyone together and to try to arrive at a shared decision. And in March, we came out with a statement saying that we're going to continue universal maskings for a period of time. That held together until midsummer or so, when there was a lot of pressure to stop, and so it fell apart. It's currently in the fall apart phase. But right now we're trying to figure out when would we go back to it. And so there's a position statement that should come out imminently, where we're going to tie metrics based upon rates of not just COVID. This is now respiratory virus protection, not just for COVID, for flu, RSV, and COVID, which will likely mean roughly that we will be masking, or at least where we are. This is a voluntary agreement. You don't have to do this, but from October through March. So will be likely what we end up doing. Just to mention this, nothing has changed with isolation in the healthcare setting, and it continues to befuddle people. There is guidance for the general community, and there's guidance for healthcare that includes healthcare workers, and it includes patients coming into healthcare. And essentially, you have to isolate for 10 days. You can shorten it to 7 days if you do a negative antigen test on day 5 or day 7, but it's still 10 days, not the 5 days that you hear in the general public. So that always creates confusion. And of course, it assumes you're not immunocompromised and that you haven't had severe COVID. Severe COVID means you're hypoxic. It doesn't mean that you were in the ICU. If you were hypoxic with COVID, it's a 20-day isolation. That hasn't changed. It seems long. And if you're immunocompromised, it's at least 20 days with 2 negative antigen tests 24 hours apart after that. And it actually says, and call ID. That's the official CDC guidance on this. If you're a healthcare worker and your organization is still operating under contingency staffing guidance, then you can come back to work after 5 days wearing a well-fitting mask. My organization actually has moved away from that. We're now back to 10 days because we just didn't feel we had enough staff out with COVID right now to make a difference. COVID rates are going up. We'll see if that conversation changes. So you probably haven't heard of this. This is enhanced barrier precautions. This is a new thing from the CDC. It's a category of transmission-based precautions for nursing homes, long-term care facilities. It recognizes the fact that they are a big vector of transmission of multi-drug resistant organisms. It attempts to provide targeted gown and glove use during high contact resident care activities. And you could consider doing it for anyone with an indwelling device or wound. You don't need a private room. You don't need dedicated medical equipment. So the difference here essentially is that you're going to gown and glove up when you're doing something specific to the patient and not just entering the room. And it's trying to walk this line because with a lot of the new nasty organisms, the CDC has said you have to be in precautions forever. There's no stop date. And they recognize that if you live in a nursing home or a group care home or adult family home or whatever, that this can be problematic. Just to say, what are the nasties that they're talking about? Pan-resistant organisms, carbapenemase-producing Enterobacterales, carbapenemase-producing Pseudomonas, carbapenemase-producing Acinetobacter, Candida auris. And you could consider it for MRSA, ESBL, VRE, Pseudomonas, multidrug-resistant Pseudomonas, and Strep pneumoniae. But it's really those carbapenemase producers, Candida auris, those are the things they're targeting. High contact activities, it's exactly what it sounds like. Dressing, bathing, showering, transferring, really close contact with the patient. There is also CDC guidance on the nastiest of the nasties. This came out in December of 2022. It's called the Interim Guidance for Public Health Response to Contain Novel or Targeted Multi-Drug Resistant Organisms. It divides things up into 4 tiers. Tier 1 is essentially something new or never really seen in the United States that they're really, really worried about. Tier 2 is something that we've kind of seen, but we're still worried about. Tier 3 less so, and Tier 4 is when it's endemic. And the idea of these tiers is there's different levels of containment, ranging from when it's really not present in the area until it becomes endemic, in which you would do less stuff. I won't go through all of this, but I'll just say that it's stringent, more stringent for Tier 1, less so for Tier 4. If you have a Tier 1 organism in your facility, they're going to ask you to swab probably everyone on the floor for sure, if not everyone in the building. They might even ask you to swab the healthcare workers. And so it becomes a big deal. For Tier 2, it's a little bit less so. They're probably not going to swab the healthcare workers. They're not going to swab the whole facility. They are going to swab everybody on the floor. And then they track and try to see where people have gone and notify them as well. And then Tier 3 and Tier 4, less so. For all of these, their guidance from the CDC is that they essentially come in and audit you. They want them to come look at your practices, see what you're doing, give you advice on what you can be doing better. Really focus on the basics, hand hygiene, wearing appropriate PPE, cleaning equipment appropriately, cleaning the room appropriately, using the right disinfectants for the right time. They're gonna come in and look at you hard because they're really trying to keep these from spreading. The other, and I will tell you that I've been involved in a couple of these now with some of the carbapenem-resistant organisms where the guidance really changed. One comment I'll make is it used to be in the older version of this, if the patient was in precautions the whole time, you didn't have to worry about it. With the new guidance, they don't care, precautions or not, they want you to go and look because they're recognizing a lot of people aren't wearing precautions correctly, as well as the equipment isn't being cleaned and it can be spreading from person to person. This is the new CDC guidance that is being proposed. We'll see if it actually makes it out, but just so you've heard some of this, routine air precautions, that'll be your mask for the most part. Novel air precautions, which is for something new or different, like SARS-CoV-2 if that ever appears, or a new influenza when it comes out. And then there's extended air precautions, which is our traditional airborne. And it's kind of reflecting this evolving science that, just like with COVID, it's mostly droplet, but there is a role for a respirator sometimes. And it's trying to say it's not black and white, it's not one or the other, but it's a spectrum. And the new guidance will likely reflect that. Water management, where there's increased awareness that water can spread infection, whether that's from coming out of the tap, whether that's splashes from the drains. And there's a lot of focus on this right now. Sinks, drains, toilets, hoppers, potential sources of spread. And lots of organisms have been implicated. That list grows all the time. And so what they want you to do is recognize that it's splash droplets that cause most of the trouble. So don't store anything within 3 feet of the edge of a sink. So if you have a counter next to a sink, you really can't use it. It's kind of pointless. You have to clean that surface regularly in case someone does sit something down on there. And you don't want to have the water coming directly out of the drain or out of the faucet into the drain because it'll splash back. They want it offset, which means that the water comes off to the side. You want to use the sink with an adequate depth and not too much flow of water to prevent splashing. Toilets and hoppers need to have covers. So this is a requirement at this point. I don't know that everyone's doing this. When flushing, you need to have a cover over it to keep it from splashing, or you shut the door when it shows. You don't want to discard IVs, medications, nutrition products, drinks, and food down the sinks because that just serves as food for bacteria to grow. And I'll kind of close here with Candida auris. It's a multi-drug resistant yeast spreading throughout the world in the US, first identified in Asia in 2009. First Washington case identified this year, so you may have heard of this. It was, I'm sad to say, at one of the Virginia Mason Franciscan Health facilities. It can cause invasive disease like bloodstream infections, and in those who get invasive disease, up to a third die. I will say in general, invasive disease from yeast is bad anyway. There's a fairly high mortality, whether that's the yeast itself or it's a marker for how sick they tend to be. But Candida auris tends to be treated by echinocandins, so mycofungin, caspofungin, but not always. And so you just have to watch. It can also make you colonized and not sick. Risk factors are just long stays here, healthcare in other parts of the world or the US where there's a lot of this. And just be aware that not all disinfectants kill Candida auris. There's a special EPA list. So if you use a quaternary ammonium Sani-Wipe, it doesn't kill Candida auris. The super Sani-Wipe, which has that plus alcohol does, bleach does. There are things that kill it. Alcohol-based sanitizers do it. Hot spots that are here, this is the CDC's list. It hasn't been updated yet to show Washington, but there are other places. Like I have friends in public health in LA County down in California, and they're like, Candida auris is endemic. I don't know what to do with it. So I feel like for us, it will eventually get that way, but you may hear about that. So thank you. I'll stop there. Any questions on the world's most important but most boring topic?
Again, thank you so much for this exciting presentation. This is something that I normally debate with my colleagues during coffee break. Like when we are seeing patients, we talk about wearing lab coat. Does wearing lab coat have any protective effect on infection control?
I don't think it protects the patient. I don't think it protects you. I think it's equivalent to just wearing coats. And as you may know, the UK actually some time ago banned ties, and then they banned things below your elbow. So you have to wear, if you're going to wear a dress shirt, it's supposed to be like a short sleeve dress shirt, and if you're supposed to wear a lab coat, it's supposed to be a short sleeve lab coat. And I've been waiting for years to see like a report get published because it's a nationalized healthcare system. They should be able to tell me, did that help or hurt their infection prevention practices? And they've never come out with anything. And my friends in the UK, when I talked to them, you know, they said part of the reason is because it's not really enforced. And so some people do it and some people don't. My personal opinion, the lab coat just becomes a big dirty fomite that you spread around everywhere. And it makes sense not to wear it. I think we wear it as a badge of office, right? It's the barber's coat from back in the day when surgeons were barbers and they would wear the white coat. Now, I will say one of the things that I've always liked, I have a patient who's a doctor from Switzerland. And apparently in Switzerland, I can't vouch for this personally, but according to him, when you come to work, everyone, doesn't matter what you're doing, goes to a locker room and changes. And they put on actually bright white scrubs. And they go about their day. If they get dirty, they go back and change it. They get separate shoes. All of these are provided by the hospital. And then when they leave, at the end of the day, they change those out and go home in their home clothes. And I've always thought that that's a really nice idea to keep us cleaner, make sure that you have clean stuff when you go see your patients. It's going to be really obvious when your white scrubs get dirty, you're going to try to change it. And it keeps you from taking stuff home with you. So that's something that I've been a fan of, but I've never been able to convince an administrator in the United States to pay for that. And I just personally, I never used to wear a lab coat. This actually was my outfit for work. Although I will also say I would only clean my vest once a week. With COVID, I did start wearing it, mostly because now I'm wearing scrubs at work and I haven't switched back. I probably should.
Concerned about the sink flashing. Does that also apply to home? Like they're worrying about the brush kept on the counter?
At home?
Yeah.
So the question was the sink splashing, does that apply at home? Yes, it does. I don't know why it'd be any different. We probably have less rigorous maintenance of our home faucets and sinks than we do elsewhere. But that bacteria has got to come from somewhere. For the most part, the idea is that it's a patient who's contaminated that somehow contaminates a sink or a drain or a shower drain. Whereas at home, that would probably be you or people living closely with you. And so the risk therefore is less. You're also probably not as compromised as somebody in the hospital who has, central lines or Foley catheters or chest tubes or whatever that may be. So our risk is lower, but yeah, the principle is the same. And it's actually kind of scary what they grow out of these sinks. They find all sorts of stuff.
I have a question from someone watching virtually. They're asking, what are your thoughts on doffing in the hall outside a clinic room after seeing a known sick patient? All other patient and staff walk down that hall to exit the clinic.
So in general, you doff inside the room. That is the guidance. I will say that we're struggling with this at Virginia Mason because during COVID, we had everybody come out of the room and doff, and we're just trying to get back to what was always normal practice. So the theory is that you're all gowned up before you go in the room, and then you doff on the way out of the room. And I get a lot of questions about what do I do for C. diff? Officially, you doff, wash your hands, and you leave the room. What do? I open the door, I remove the curtain aside so I don't have to touch it. I doff, I wash my hands, I leave. I'll shut the door if the patient wants it, and then I'll find a sink and wash my hands again. But you do doff, you are supposed to doff in the room, and it is for that logic, that the room is where the dirty stuff is, and you want to keep the rest of the environment clean.
I have two questions. One, what's your guidance on MRSA isolation in the hospital? The other one, how do you deal with infection control with patients that have pets with central lines?
So the first one's easier. So officially, MRSA still requires contact precautions on CDC's Appendix A. And so we still do that. There are a lot of facilities nationwide that have stopped doing that with the argument that you would only do contact precautions maybe in the setting of a MRSA outbreak in your facility. The problem with precautions is there's a lot of science about the negative impacts of them. We do it as a measure of protection to help other patients, but those same studies or the other studies will show you that people go in the room less frequently, including healthcare workers. Patients feel more isolated, they get worse care. And it just takes more time and effort and cost to do all of that. And so several facilities that have really good data to say, we don't have an issue. We've stopped, we know what our rates are. We stop precautions. We still don't have an issue. They have done that. It tends to be academic centers. I have brought that up at my own facility and been shot down by infection prevention just because it isn't in the national guidance. Plus, it just opens yourself up to a debate with a regulator or a lawyer about why do you not follow the CDC guidance? Who are you to say that the CDC guidance isn't enough? If I'm Massachusetts General, maybe I can say, oh, I'm Mass General, and so, I'm right, you're wrong. But when you're a community hospital system, it gets harder. Central lines and pets at home. I always tell my patients, don't let the animals lick anything. So if you have an open wound, don't lick it. If you have a PICC line, don't lick it. If you have a port, don't lick it. And actually, for the first time in my career, maybe, I had a patient that I saw this week who is a nurse practitioner who has a port put in for chemo. And right after it was put in, she awoke to have her cat licking the wound. the new incision. Nothing happened. They had glued it shut, so I presume that the glue was the barrier, and then she did try to clean it up afterwards. But it does illustrate that there are animals that will like to go and lick open wounds or things like that, and they should not. But at some point we have them have central lines so they can, at least in my world, in infectious disease, so they can go home, do their antibiotics, not be in the hospital, so they can go live their lives. And if their pet's important to them, which it probably is, there's only so, be prudent about it, be smart, but you can't stay away from them altogether. It's the same advice I give to my transplant patients. They'll sometimes see us for advice pre-transplant when the surgeons are worried about them. So I remember one guy who was an organic farmer who would go around and do everything in the farm. And, I had a little talk with him and I said, you just have to be prudent and realistic. If you think that you are going to be in contact with something, try not to wear a mask if you're in the chicken coop, right? Try to not, clean up the poop everywhere when you're in your farm animals, or if you do, wash your hands later. But at the same token, he's getting the transplant so he can keep living his life. And that's what he does. That's what he loves to do. At the end of the day, our jobs is to counsel and give guidance and try to keep it pragmatic, although that's hard. And the regulators are not pragmatic. I will tell you, it is very black and white. You either do it or you don't. And you have to do it.
I have another question here. What would you say to the people who refuse precautions because they think it will cause superbugs?
It will cause superbugs?
Yes, that was the question.
Well, I guess I would try to understand. I wouldn't know what to say because I don't understand why they would say that. But we do have people that refuse precautions. If they're staff members, they don't have a choice. They have to do it. And that's partly why we're making everybody sign a piece of paper that they know what to do, because if they don't do it, we're going to come down with from an HR standpoint, because we're that serious about it. From a patient standpoint or a patient's family standpoint, again, I think of it as advice and counsel, and then they can choose or not choose to accept it. That's my personal opinion. I know our infection prevention team at Virginia Mason is pretty strict, and our nursing leadership is pretty strict. And so depending upon the nurse leader, they may tell the patient's family, if you're not going to follow the precautions, you can't be here. I've seen that happen. Which, is not wrong, but it is harsher. One of the things is if they don't follow precautions, they can't wander around the hospital. They need to go and they need to leave. They can't go to the cafeteria. They can't do all this other stuff. But, how do we know that? We can't enforce it. And they're still using the elevators. They're still touching the buttons. That's kind of the argument for why we should be strict with them.
I have a question regarding staff that goes into patients' rooms and they sit on the patient's bed and then they sit on their chairs and then they go to the next room and do the same thing.
So in theory, the patient's bed is going to be as dirty as anything because that's where the patient spends most of their time. If they have something that's in precautions, then I guess in theory they have a gown on that if they tied it in the back will give them some protection. But would advise not to. You could argue that's true also for the chairs to some degree. I mean, at one point, I was taught not to sit on the patient's bed. That it was disrespectful, and it was more of a humanism thing. And then at some point, someone else was said, "No, you should do it. Patients really like it." And so I do not sit on beds. I guess I'm old school that way. But it's always a concern. Chair to chair, the risk is probably lower. Even the bed, again, if there are precautions, do it. I will tell you, I tend not to sit. I mean, I don't sit on the bed. And I actually tend not to sit in chairs. That's more just because I spend enough time sitting during the day. And so I like to stand. But for some patients, it's a long conversation. They want me to sit, I'll sit down. I will say, being a hypochondriac, that when I go home, I will pretty quickly change out of my work clothes into something else. But then I launder them with all my other clothes, so I don't know.
Any recommendations on stethoscope cleaning?
Well, not a requirement. The stethoscope is a shared medical device, so it needs to be cleaned before and after use with the patient, essentially. So what I do is I take the sandy wipes that are usually on the walls and I'll wipe it down. You can use alcohol too. You can use soap and water, doesn't really matter. You're just trying to clean it up a little bit between patients. So that's another area. I really like Seattle Children's, where they had a dedicated stethoscope in every patient room. And it was like a high quality stethoscope that they reprocess. I didn't, so you actually, you don't have to wear a stethoscope. And you don't take it from room to room because you just expect every room to have a stethoscope. I've never been able to get anyone to pay for that either. I actually asked Seattle Children's how much it costs, and nobody remembered. They've been doing it for so long, so there was no price that they could add to it. But you do need to do it when you go from patient to patient, and it is something that is very frequently not done. I think providers don't think about it and forget about it, but you can be called out by a regulator.
I have a question on how do you practice those history of ESBL and BRE in your institution?
So we isolate them. Also debatable, VRE less so in the CDC guidance, but ESBLs are debatable, but we do isolate them. How long to isolate? This is another bugaboo in infection prevention. There's no great answer. Forever is probably too long. At some point it's too short. They still have it on them. Unless you're actively swabbing or screening or reculturing, you may not really know. When I started working at Virginia Mason, all of these things were isolated for life, we had a complicated way to swab them to get out of it. They had multiple negative swabs. When they weren't on antibiotics that treated that organism, you could come out of precautions. But then we changed it. Shortly after I got there, we made it 18 months, which we made up. There was a study saying 2 years and a study saying 18 months, and we picked the shorter one, but neither one were great studies. With COVID, we reduced it further just because we actually didn't have gowns, right? Isn't it crazy? Like we didn't have all this basic stuff. And so we made it 90 days. So for most things at VM, we now isolate for 90 days. Exceptions are the list of high-risk pathogens that the CDC's called out, your carbapenem-resistant things, Candida auris. Those we still follow the CDC guidance, which is to isolate forever. CDC knows that's too long, but they don't really know what to do with it. And so I think we're kind of stuck until they come up with something new. So thank you, everyone. Enjoy the conference.
Thank you, Dr. Baliga. It was a great talk.